Hello, everyone. Good evening. Welcome to the fourth episode of ICPA Clinical Series, where we try to solve one clinical challenge in every episode. The tagline you all know each episode, one clinical challenge. And today we have the pleasure and privilege of having Dr. Surabhi Mahidhar with us, who is going to discuss on one specific topic that is screw retained restorations in implant dentistry. And Dr. Surabhi Mahidhar is an MDS prosthodontics. He has done his BDS and MDS both from JSS Mysore. He enjoys his private practice at Madanpalle, Andhra Pradesh. He has been conducting workshops for over 10 years now, which are mainly focused on full mouth rehabilitation and implantology. He is the founder of SM series of prosthodontics. SM stands for Surabhi Mahidhar. SM series of prosthodontics that has helped many graduates and postgraduates in the year 2020 and 2021 through more than 125 online discussions and webinars. Dr. Mahidhar has also founded SM Dental Study Group, which conducts hands-on workshops on FPD procedures, full mouth rehabilitation, as well as dental implants on patients. And today he is with us to discuss, throw light, and give some clinical resolution to some of the clinical challenges that revolve around the topic screw in or out, a tale of screw retained implant prosthesis, clinical complications, prevention, and management. So, looking forward to have a great session from Dr. Surabhi Mahidhar. Surabhi, the stage is yours.
Thank you so much, Rajiv sir, for inviting me and having me here to discuss on a very interesting clinical topic, which is screw retained implant restoration. When it comes to the complications, prevention and management, I thought this would be one of the best topics to discuss in ICPA. So thanks to ICPA as well for having me here to discuss this in brief about what all clinical problems do we face or encounter in our day-to-day implant practice, how to prevent them, and how to manage the same at the same time without panicking. So I'll take over with the presentation now. I'll start off with the presentation. So can I have the slides on the screen, please? Am I good to go?
Yes, Surabhi, you can start. Your screen is visible.
Yeah.
Yeah,
Thank
yeah,
you,
yeah.
sir. Thank you so much. Yeah. So we'll start off with the presentation. I've named this topic as screw in or out because, see, we usually take the implants in bone, we fix the implants in bone, and then we restore the implants with a screw. Basically, if you think about the abutment or think about the prosthesis, the main component that goes into the implant is the screw. So when we screw in, what happens if it comes out? That's the main intention of the topic and how we have to deal with these things in our day-to-day implant practice. As many of you know that implant placement is more of prosthetic than surgical. Yeah, with due respect to the surgical placement inside the bone, it's always the prosthetic planning that goes well with an implant than the surgical planning. We need to actually see that the implant goes into a prosthetic position, and then after 3 months of osseointegration, or if you're immediately loading it, you are placing the restoration in the correct prosthetic position. Randomly, if you just place an implant inside the bone surgically, if it is good enough, also later on, if the restoration is not in its prosthetic position, it might be a failure. So it's always the prosthetic placement of an implant that actually counts when it comes to implantology. You can take the help of a surgical guide, a manual guide, which you can make it by yourself in the clinical practice. You can also take the help of CBCT. You can go with a CBCT guided placement. The only advantage of CBCT guided placement is you get the orientation, you get the angulation, you get the position as well as the depth of an implant in the correct sense. So CBCT plays a major role in placing an implant. And if you don't have these two, let's say that you don't have time to use a surgical guide, if you don't have CBCT around you, if you're practicing in a town, then yes, you can take the help of the opposite functional cusp as well into account and place an implant arbitrarily in that prosthetic position by seeing the functional cusp or on the opposite arch. So that is okay. I mean, that comes with experience. But if you broadly classify and see the prosthetic placement of an implant, I would suggest either this or this. Definitely. Why do I say diagnostic cast is a must? Because if you directly see into the oral cavity, we have a binocular vision. So most of the times we might miss on the undercuts, we might miss on the tilts, we might miss on the supraeruptions, many things when you see inside the oral cavity, just visually. Rather capture in the form of a diagnostic cast, take it in hand and see, you can see all these things clearly. You can see the undercuts, you can see the supraeruptions, you can see the drifting that has happened inside, you can see the edentulous span that is exactly existing on the edentulous cast or the dentulous or partially edentulous cast, whichever. So you have to make sure that a diagnostic cast is made before you place an implant. You can also assess the prosthetic space that is available for us. Suppose you don't have much of prosthetic space, which kind of restoration do I have to go in with? If I have good amount of prosthetic space, can I go with either a cement retain or a screw retain? So we can decide on the type of restoration as well if you have a diagnostic cast with you. So important point here is, please make a diagnostic cast before you actually plan and place an implant inside the oral cavity. Broadly, the implant restorations are classified into two. One is screw retained restoration and one is cement retained restoration. The basic difference between a screw retained and cement retained restoration is, see here, if you have an implant, you have a crown assembly that is screwed in the implant as one unit. So you don't have an abutment separately, you don't have a crown separately here. You have one assembly which is actually torqued in, which is actually placed inside the implant with the help of a screw. So this is known as a screw retained restoration. But when it comes to cement retained restoration, it's just like your FPD or a crown that you make on a natural tooth. So you have an abutment separately which is screwed in inside the implant, and over this abutment you cement a crown. So that is the basic difference between your screw retained restoration and the cement retained restoration. In order to make the cement retained restoration retrievable, because if you loot this crown over the abutment, most of the times, in case there is any problem with the abutment inside, if there is any problem with the implant inside or the soft tissue around, then you might have to cut the crown, remove it, and then see what is happening inside. Rather, we change this cemented crown into a retrievable crown in the form of SCRP, screw cement retained prosthesis. So we make an access hole here, we cement it, we remove the excess cement, and then we make this access hole available to us in the future in case I want to retrieve either the crown or the abutment and see what is happening inside. So we have basically three types now. One is screw retained restoration, one is cement retained, and one is screw cement retained prosthesis or the restoration. Basically, we have these kinds of screws in implantology. Right from the basics, let's start covering up. So you have a cover screw here, which goes into the implant. You have a healing abutment. That also has a screw which goes into the implant. And you finally have a prosthetic screw which goes inside the implant and makes sure that the restoration is intact over the implant. What is the basic, indication, advantage, and contraindication of a screw retained restoration? The first thing is, if the prosthetic or the restorative space is very less. Let's imagine that I have almost 3 to 4 millimeters of prosthetic space and I need to place an implant and a crown. Then that amount of space will not favor for a cement retained restoration there. Because we all know for a looting purpose, if you want to loot a crown over a natural tooth, or if you want to loot a crown over the abutment on an implant, you need a good prosthetic space. You need a good ferrule, basically. So if you don't have that prosthetic space, the main complication that arises with the cement retained restoration is it keeps getting dislodged. The crown keeps coming out. So in order to counteract that, in order to avoid that problem, we go with screw retain restoration. A screw goes inside the implant and makes sure that the retention is enhanced for the restorations. So the first indication for the screw retain restoration is if the prosthetic space is less, and if you want to retrieve it later on, then you can go with a screw retain restoration. That's the main advantage. Anytime you want to retrieve the restoration, anytime you want to retrieve the crown over the implant, then the best solution, the best restoration that you give is your screw retain restoration. Sometimes if you place an implant in a wrong surgical position or a wrong prosthetic position, it could be a wrong surgical or it could be a wrong prosthetic. Then what happens? The future restoration axis comes labial. And what happens if the screw access hole opens up on the labial side? Then it is not that aesthetic. It is not that pleasing to look at, because we need to close that with a composite. And however good our composite skills are, then there will be an interface that is always seen. So in such conditions where the screw access hole is in the aesthetic zone or in the facial zone, then we cover that abutment with a cement retain restoration. So that is one of the contraindications of a screw retain restoration, where the access hole is labial, especially in the anterior zone, where we need more aesthetics to come into play. It is also not preferable when there is limited mouth opening. If the patient cannot widely open the mouth, then simple logic is I cannot take the hex driver in, I cannot place it inside the implant and screw in the abutment inside. So it is not preferable when there is limited mouth opening. And if the restoration is two-way posterior, let's say that I am doing an implant on 1/7 or 2/7, where I cannot access the implant with a hex driver. I cannot take the hex driver inside too posteriorly and give a screw retain restoration. In such cases also I can go with a cement retained crown. So these are the basics of a screw retained restoration. Let's see the workflow before we hit the complications, prevention management. How do we proceed with the screw retain restoration? Briefly, first thing is diagnosis. Yes, definitely diagnosis plays an important role in any branch. I would not say that it is only in implantology. In any branch, the first thing is diagnosis, and once you diagnose, then you have to go with the treatment plan. The treatment planning is prosthetic planning, basically. So you have to see the prosthetic position and then place an implant. You also have to decide which type of restoration you are going to place, whether you're going with the screw retained, you're going with cement retained, or SCRP, whichever is feasible according to the case. And finally, we place an implant. Once you place an implant, you either go with cover screw or you either go with the healing abutment. See, most of the cases where you get good primary stability inside the bone, we tend to place the healing abutments and cover around the healing abutments. And after 3 months, after 2 months, when the patients come back to us, we have good emergence profile. We have a good gingival cuff that's formed around the implants. In case the primary stability is less, if I've grafted the site with a membrane, then I would not place healing abutment immediately. I would try to cover up the implants completely with the soft tissue by placing a cover screw. So you have both the options. You can either choose a cover screw to close, you can either choose a healing abutment to close. And whenever you close with healing abutment, you take an X-ray. Why do we take an X-ray? We'll see later on. In case you want to customize the emergence, let's say I want to customize the emergence for anterior incisors. If I want to customize the emergence for posterior molars or premolars respectively, then we customize the healing abutments also with composites so that we get good emergence profile. You need to shape up the composites still better, you need to polish them still better, and then probably place an implant so that you get a good emergence profile in the form of soft tissue. Then once the soft tissue is formed, the next step is you make an open tray impression. We usually don't prefer a closed tray impression, just for the fact that I need to go pick up the impression coping from the implant. It's called implant level pickup impression, where I'll be getting the depth of the implant, position of the implant, angulation of the implant, and orientation of the implant all together. All the 3D dimensions are covered when you take a pickup and implant level impression. So when I place the impression post, which is your pickup coping inside the implant, because I've customized with a healing abutment already, I would be getting an emergence which is wider than the impression post that goes inside the implant. So I need to customize the impression post as well. So you need to remember this step, that whenever you customize a healing abutment, make sure you customize the impression post as well, and then make an open tray impression. This picture I've kept separately intentionally, because most of the times when we make a jig, we tend to go up and make a jig here. I've seen this lot number of times. This is wrong, because when you make a jig this way, if you just put a floss and then place patent resin, you have to make sure that the screw is going up and down, it's loose. The moment I place patent resin this way over the floss and make a jig, this is known as transfer jig or an impression jig, then you're locking up the screw, so you cannot unscrew it and open up and make an impression. So make sure that the jig is made somewhere nearby the slots here, which are provided by the company. Most of the companies, if you don't have those slots, you can get it slightly at the middle third or at the lower third and make a jig, not at the upper third. That's why intentionally I've placed this picture to show you that the transfer jig has to be made a little down when you compare it with the screw, which is moving up and down. Always make sure that you take a radiograph after you fix the impression copings, and then only you make the pattern resin jig. Very important. Why? We'll see later on. And once you're done with the open tray impression technique, once you pick up the impression from the implants, you have to make sure that you have to fix the implant analogs by yourself. Most of the times we send it to lab, and in case the lab fixes in the wrong direction, you will be getting everything wrong right from the impression stage. So make sure that you attach the implant analogs by yourself and then you send it to lab on a safer side. The lab will send you a verification jig. The verification jig is made by the same copings which you have sent to the lab in the form of impression. Those copings will be removed and the lab will make this jig on the cast, and it will be sent to you back. What you have to do with it, you have to check back inside the oral cavity if your impression was correct or wrong. As simple as that. And once you check back inside the oral cavity with the Sheffield test, what is this test? We will see later on. You will see that the jig which is going on into the implants inside the oral cavity is passive. What do I mean by passive? I need not force the jig into the implants. The moment the jig is kept and tightened from the distal most screw, it has to sit by itself in all the implants which are present inside the oral cavity. I need not force the jig to sit inside. That becomes an active fit. I don't want an active fit. Why? We will see later on. You finish the jaw relations, you finish the teeth try-in, everything. You finish the Facebook records, everything in one appointment, and then the lab makes a facial index, the lab makes an occlusal index, the lab makes a lingual index. All indices they make and keep it ready for layering later on for the framework. The frameworks of different types. Let's not discuss this because we don't have time for it. Different types of frameworks you have. This one which you're seeing here is the DMLS cobalt chromium framework, which is done with exocad. So once the framework is ready, you can check for the BIS trine. The BIS trine is basically done for the proximal contacts and the occlusal contacts. That's all. We're not going to do anything else. Once the ceramic is layered, then you can do a BIS trine. The final crowns in position, you have to do the trine. Passive fit has to be noticed even here. And once you get the final crowns, you give a prosthetic torque both with the manual wrench as well as with the wrench which you're seeing on the right side. It has to be done with both the hand as well as with the torque. And once that is done, then you need to place Teflon in order to make sure that the composite would not go into the screws, and then you seal it with composite. The advantage of this open tray impression technique is you get good emergence when it comes to the final crowns. You're actually capturing everything from the soft tissue level, and going onto the implants. Occlusion is very, very important. We will see about the occlusion later on, where exactly you need to place the contacts and what is the importance of this occlusion when it comes to the screw. So this is the basic flow of how you proceed with the screw retained restoration, whether it comes to a single screw retained restoration or multiple or full arch or full mouth. The only difference between single and multiple full arch full mouth is in multiple and full arch full mouth you will have these verification jigs. You will have many steps later on, but in single you need not do this verification jig because it's just a single crown that goes and passively sits. And we also have a hex to hex connection, which I'll be discussing later on. So as I discussed already, the main advantage of the screw retained crowns is retrievability. Whenever I want to retrieve the final restoration, I can open up and retrieve. I can see what is happening inside. Let's go into the complications now. Now, when it comes to the cover screw, I said we place cover screw inside the implants when my primary stability is at stake. Otherwise, I'll go with healing abutment. When I probably graft, when I have an intention to just close the site and reopen probably after 3 months in the second stage. Most of the times, if you see here, this is the main complication. You will feel the resistance, once you place the cover screw and once you torque it in. What I mean by torque it in, you don't take a wrench and torque it in, just has to apply a hand pressure, that's it. So once you take the cover screw inside the implant, we feel the resistance that the cover screw is completely fitting inside the implant. But once we take a radiograph, we see this picture many times. This is the common mistake which we do when we don't take a radiograph. This is happening because of the bone which is present around the implant most of the times. If you have submerged a little down and if bone is coming as an obstruction here, it stops there. It will not go inside. So you might have to correct the bone here and then place the cover screw correctly inside the implant. What happens if I don't place the cover screw correctly inside? What happens if I just leave it like that? Anyways, the osseointegration is around the implant, right? This soft tissue creeps in. There could be a creep of the tissue, around the implant into the space which is there in between the cover screw and the implant. So I don't want that to happen. So make sure that you take a radiograph, make sure that the soft tissue or the hard tissue around an implant is not coming in the way of your cover screw inside the implant. One more complication of cover screw is cold welding. Don't apply too much of torque. Don't apply too much of torque on cover screw. Many times it gets cold welded. And once it gets cold welded, then it becomes a difficult task for us to remove. The only solution practically you can go with is your ultrasonic tip. You just take an ultrasonic tip and rotate in anti-clockwise direction. If you're lucky enough, then it comes out. Okay, so let's see about the healing abutments now. Now, I said in the workflow that you have to take an X-ray after the healing abutment is placed as well. Because most of the times, as I said, with the cover screw, with the healing abutment also, you might have bone here, which comes as an obstruction between the healing abutment and implant. So I don't want that to happen. If that is happening, then I might have to correct the bone a little and then place the healing abutment inside. So make sure you check for the correct fit of healing abutment. And also don't over torque the healing abutment. I've seen people taking a wrench and placing 15 Newton torque over healing abutment. It might get cold welded. So a hand torque is more than enough for a healing abutment. Okay, cold welding is main issue, when it comes to the healing abutments. There's one more thing. We place composites around the healing abutments to customize the tissue, and when we do it, what happens, the composite flow that happens will be an obstruction for the fit of the healing abutment inside the implant. So make sure that the composite is not coming in the way. You correct the composite, you create a good emergence. This is unfinished composite still. You need to create a very good emergence around the healing abutment for the soft tissue creep, and then you have to place the healing abutment inside the implants. Very important aspect where we have to check for the impression coping fit inside the implant with an X-ray, with a radiograph, because many times, just like your cover screws and healing abutments, this also you feel that you have torqued it enough inside the implant, you have pushed it enough inside the implant, and you will have a lot of space. See here, it's not completely fitting. And once this happens, what happens? The whole the whole intention of making an open tray impression is lost. You're getting error here. So you have to make sure that you open up again, tease it a little, and then see for the obstruction in the form of a soft tissue or hard tissue, rule it out, and then gently, clockwise, anti-clockwise, clockwise, anti-clockwise, push the screw in, and make sure that you take an x-ray again, confirm it, and then proceed with your open tray impression. When you make an open tray impression, make sure that the screw which you remove on over the impression tray, which comes out through the window, that has to be unscrewed totally. It has to move up and down. You should see that the screw is moving up and down. If you have not, removed the screw enough, if you have not, unscrewed it enough, then you might end up in tearing the impression. You might be thinking that the screw is loose and you will pick up the impression, but the screw is still intact inside and you will tear the impression, or you might create a damage there. So make sure that the screw is loose. As I said, fix the abutment unlock by yourself. Don't depend on the lab to do it. You might have good labs who can do it, but you might also have bad labs who who cannot do it well. So don't believe in that. You yourself fix it and send it to the lab. Sheffield's test is very important because the distalmost screw, when you tighten it inside the implant, the other components also, they have to go and passively sit inside the implant. If that is not happening, then you might have to cut the component which is not going in, and again, you have to fuse that with a pattern resin. You have to fill that space with pattern resin. Send this jig to the lab. The lab will make model surgery. They will correct the model, the previous model, and then they will give you back another verification jig. You have to do the Sheffield test again, make sure that the jig is passive, and then send it back. What is the advantage of this? The only advantage of this jig is the framework which is coming next in the procedure would be 99% passive. I would not say 100%. There might be errors there as well, but the chance of errors is minimized if you do a verification jig. The passivity is checked in the verification jig, and the passivity is confirmed in the framework stage. If I don't do the verification jig, what might happen? The framework might not be passive. And if the framework is not passive, you have to go back to the impression stage and start everything back. So all the framework would be a waste. So if there is no passive fit, as I said, you either go with the impression again, you start with A and then come back to Z, or you have to do a model surgery depending on the lab. Prosthetic torque is important. We usually end up here. Many times we don't give the prosthetic torque with the wrench. So this is very important. You will have to measure the prosthetic torque, and then you have to give a prosthetic torque, which is very important. If you give less torque, it is also a problem. If you give more torque, it is also a problem. We'll see what. The recommended prosthetic torque is around 25 to 30 Newton centimeters. It depends on the company. So I would not say 25 to 30 is the standard. It is a standard according to textbooks and literature, but specific company recommendation is always better. Go with the company recommendations. Occlusion is important. We'll see how. So we'll discuss all these, factors briefly. I mean, I'll give you one takeaway from all these things so that it becomes practically feasible for all of you to go and manage. When it comes to occlusion, very, very important when it comes to a single crown posteriorly or multiple crowns posteriorly. I'm talking about the posterior area, not talking about the anterior. So when you are having a single crown posteriorly, whether it's a cement retained or screw retained restoration, usually the natural tooth will have an infraocclusion of 28 microns inside the socket because of periodontal membrane, as simple as that. So when you give a crown on an implant which is not having a periodontal membrane, it's rigid inside the bone, it has probably around 5 microns of infraocclusion inside the bone. You might have to infraocclude it prior itself. When the lab makes it, probably we might have to instruct the lab to infraocclude by 28 microns and give it back to us, so that once we screw in the crown inside the implants, it is infraoccluded already by 28 microns. So when the natural tooth goes down, it becomes in alignment with the implant crown. Otherwise, what happens? The natural tooth goes down by 28 microns, the implant crown sticks out. It acts as interference there. So we have to be very careful in that. So you can take an articulating paper, you can take a 40 micron articulating paper and check for it. You can also take a 12 micron, fold it twice, and also check for the infraocclusion that happens with the implant crown. So there is a formula. I mean, you can just remember the statement: light closure, no contact; heavy closure, light contact. So if there is a light closure, there should not be any contact on the implant crown because it is infraoccluded already by 28 microns. And if there is a heavy closure, the tooth next to the implant crown goes down by 28 microns and comes in line with the implant crown. So there is a light contact on the implant crown. This is a very important point which has to be practically followed. If you see here, there is no contact on the implant crown, but there is a light closure on the natural teeth. Here, a heavy closure on natural teeth gives a very light contact on the implant crown. This has to be followed practically, then it serves a long purpose. Anteriors, usually if you have a single implant, we don't give any contacts, we don't give static or the excursive contacts on the anteriors, but you create the guidance on natural teeth. But you have multiple crowns on anteriors, yes, you give grazing contacts. What is grazing contacts? Very, very mild contacts on the anterior, so that they act in excursions. It's always a shallow excursion that happens with multiple implant crowns in the anterior region. When you have canines as an implants, make sure that you give a partial group function or a full group function according to whether the premolar is also an implant. We don't know. But when is a canine is an implant, then yes, go with the partial group function. Take the support of premolar also. I don't want the load completely falling on an implant because it is osseointegrated. It does not have a periodontal membrane. It might fail. So I want the premolar also to take the load. When it comes to full arches or full mouth implant restorations, screw retained restorations, it is always a mutually protected occlusion with shallow group function. Everything has to be shallow. The cuspal inclines has to be shallow. The compensatory curves have to be shallow. The anterior guidance has to be very, very, very grazing contact shallow. And the lateral excursions also should be very shallow with group function because it's an implant. If it's a natural tooth, we go with the canine guided occlusion. We need all the this disclusion of the posteriors. But when it's an implant, then yes, we depend on a shallow group function so that the forces are dissipated, the forces are shared amongst the implants. Now, when I was talking about the prosthetic torque, I said less torque is also detrimental, is bad. Why? Because if you give less torque, the patient keeps coming back to you with the loose crown. So give an adequate torque. Give a prosthetic torque which is adequate. If you give more torque, what happens sometimes? Either the screw which is going inside the implant damages the threads might get worn away, or you might have fracture of the screws also inside the implants. Sometimes cold welding as well. So you have to follow the company recommended torque, stop it there. Do not over torque, do not under torque. There is something called settling. I mean, what is settling? See, once you give a torque to a screw inside an implant, what happens is you have something called a preload. Preload is the torque which is given, and you have clamping forces and you have joint separating forces. Clamping force is the force which will join the screw and the internal surface of the implant. It will combine it. When you have joint separating forces which are acting on the restoration, those forces will try to unscrew the component inside the implant. These are called joint separating forces, which could be tensile forces, which could be overloading of an implant. So in such cases, what we do is we do it's called settling. We do something called torquing the screw again, probably after 10 to 15 minutes. Once we apply the torque, we make the patient sit for 10 to 15 minutes. We call the patient back again, and again you unscrew it and torque it. So the settling concept works practically well in a single appointment. There are literature supporting the settling concept after a week also. Practical enough? I doubt. So after 10 to 15 minutes in the OPD itself, you can finish this, giving a torque again. Always use a wrench. Suppose you have surgical misplacement of an implant, uh, then it is usually not good. Anteriorly angulated implants are allowed still because you can tilt the abutment, you can make the prosthetic component parallel inside the oral cavity. But when it comes to posteriors, I don't want an angulated implant for a single angulated abutment for a single implant, because that angulation might be a detrimental factor. Again, screw loosening, screw fracture, sometimes prosthesis fracture, and sometimes implant fracture. We don't know, and crestal bone loss. So we don't want any angulated abutment over an implant in the posterior region, especially. We want the implants to be placed perpendicular to the plane of occlusion. Very important. It has to be perpendicular to the plane of occlusion in the prosthetic position. So posteriors, kindly stay away from angulated abutments. But when it comes to all on four concepts, when it comes to splinting of the framework together, yes, it is allowed. Make sure that there is no prosthesis misfit as well. This is a very important concept again. If there is a prosthesis misfit that is happening, then it could be a problem again. So make sure that there is no misfit of the prosthesis. Cantilevers, yes. Single implants not allowed. When it is multiple implants, you can place cantilevers because the framework is splintered. Make sure that the size of prosthesis is not big. It should not be like a natural tooth. Make sure that it is buccolingually slightly smaller than your natural tooth, so that there is no horizontal cantilever that is falling buccally or facially. The occlusal contact has to be on the central fossa usually, but if it is not on the central fossa and if you have composite there, you can give 1 millimeter peripheral to the central fossa in the form of peripheral occlusal contacts. You have tooth implant supported prosthesis, which is again not a very good factor. It should not be supported. When you have a tooth implant supported prosthesis, then the implant and the tooth, there is a discrepancy there. Parafunction, it's an absolute contraindication for me. I would not prefer placing implant in parafunction patients. Rather avoid most common etiology for screw loosening or screw fracture. Do not use old screws or used screws for implants, because if you are using old screws or used screws for implants, then usually they fracture. Only the old screws are used by the lab. When you want to mill probably an abutment, they use an old screw, mill it and send it back to you. You use a new screw and place it inside the implant. Screw loosening, yes, you have to check for the etiology first. The main etiology of screw loosening is occlusion. Very, very important. If you have tensile forces, then yes, you might have this screw loosening happening. Screw fracture, also one of the major complications. Use an ultrasonic tip. Make sure that you rotate the ultrasonic tip in anti-clockwise direction. I have a video, I'll show it probably at the end of the presentation, and make sure that the screw is out. When you have single implant, make sure that the abutment has a hex, because it acts as an anti-rotational feature. But if you have multiple implants, then you can use a combination of hex and non-hex, just to make sure that the framework is passive inside the implants. UCLA abutments can be preferred over the normal customized abutments, because you have a base here either in the form of cobalt chromium or in the form of titanium. So that will prevent the casting errors finally. So the final factor for overloading is your prosthesis failure or an implant failure with crustal bone loss. So all these factors, if we remember clinically, then the overloading concept would be minimized. Main point here is occlusion. If you are taking care of occlusion well, then yes, most of the screw loosening or screw fractures are avoided. Compressive forces are always beneficial. Please remember that tensile forces are the big factor for screw loosening or screw fracture. Takeaways: plan the processes before placing an implant. Occlusion, as I said, is the most important factor. Forces should always be directed along the long axis of an implant. Compressive is always beneficial and tensile is always detrimental. Bone implant contact is a very essential aspect of crustal bone maintenance. As much as width you have in the bone, utilize it. Increase the bone implant contact. Place a wide implant. If you have good amount of bone, probably when it comes to the length, utilize it. Over engineering is always better. But literature suggests that after 10 mm, there is no biomechanical extra benefit when it comes to the load. But utilize when you have probably D3, D4 bones. Recommended prosthetic torque is always to be applied. Do not under torque, do not over talk. So this is my Facebook ID, Instagram, Gmail, and clinical Facebook page. You can log on to these things. If you have any doubts, you're always free to ask me. I'll always be there to reply. Takes a little time, but yes, I do reply and make sure that you all get the feedbacks or the answers, replies. We are going to conduct an implant prosthetic workshop in Mumbai. It's in November 26th, 27th, 28th. So anyone is interested, then we have a live patient demo. Also, you can walk in and utilize the workshop. Thank you so much again. I hope I've covered most of the clinical points in brief. Because we have less time, I could not cover with the deeper aspects of screw retain restorations. But these are the clinical complications, preventions, and management when it comes to the screw loosening, screw fracture, probably prosthesis failure or an implant failure around the bone.
All right, Surabhi, it was wonderful. A very complex and very big topic, but you did justice to it. You took us through the entire workflow at all, through all the significant, what you can say, steps and possible complications, how to prevent them and how to manage them. Some of the points which are very that can be a very vital importance to a beginner are uh, implant placement has to be ideal if you want very good prosthetic outcome. Always verify with the X-ray, even if it's a simple cover screw, and don't assume that you have got the best fit if you have just encountered good resistance. The X-ray may show a different picture. Torque should not be too much. It may lead to fracture, and it should not be too little. It may lead to screw loosening. And it is always better if you adhere to the company or manufacturer recommendations. Occlusion is critical. A very simple rule you said: if it is light closure, no contact, and heavy closure, light contact. And on incisors, either no contact or you can just give light grazing contacts. Passivity is critical, and where you need to employ Sheffield test. And when it comes to parafunction, it's an absolute contraindication. I think this covers the salient points of the lecture.
Thank you, sir. Thank you so much. Yes.
Okay, so let
Uh,
us take some of the questions. You want to add something?
shall I just show just 1 minute video, sir? Ultrasonic.
Yeah, please go
Yeah.
ahead. Please go ahead.
Is it visible on the screen?
Yeah, it is getting loaded. Yes.
So just a small video to show that if you use an ultrasonic tip and rotate it anti-clockwise, then probably the crestal and middle third screw fracture could not be an issue.
Great. Uh, I think we have a lot of questions here. People who had registered beforehand
Yes.
have sent many questions. I'll take them one by one.
Yes, sir.
So the first question is there any particular kit which you prefer or recommend to the doctors to retrieve the broken screws?
We have many kits. I mean, every implant company has its own kit. We have, I mean, I have used Maceran kits also, which are used to retrieve the root stems, which are used to retrieve the root canal broken instruments also. We have many kits which are company provided as well. But when it comes to the screw fracture, which is probably crestal or middle third, the best kit which can be used is your ultrasonic tip.
Okay.
Otherwise, you can get it from the company and use it. You have Vein 83 kit, which is available.
I think Dr. Mahidhar lost his connection. Let's hope he's back soon. Sorry for the inconvenience. Let's hope he comes back soon. It was a technical problem. Some of the questions asked by the audience. The first one I asked just now: is there a particular kit which he recommends to the dentist to retrieve broken screws? Next, some of the questions are: instead of screw retained, just hold on. Okay, instead of screw cement retained restorations, why can't we go for screw retained restorations directly? Is there any advantage for screw cement retained restoration other than retrievability? And difference between cement retained versus polymalo crown? And these are the three questions that I'll be asking Dr. Mahidhar as soon as he joins back. He just gave me a call that he had some technical problem and he's joining soon. And then any guidelines for fractured screw removal? What can we do if threads in implant don't hold the abutment screw due to wear from repeated tightening? I think this is a very, very relevant question. He'll be more than happy to answer this. Is cement retained prosthesis with access hole in crowns a better option than screw retained prosthesis?
So I'm back.
And hi, good, good, good. Okay, I was just reading out some of the questions people had asked. You have answered the first question. Second question is: instead of screw cement retained restoration (SCRP), why can't we go with screw retained restoration directly? Or is there any advantage with screw cement retained processes other than retrievability?
Yeah. See, as I mentioned in the presentation, probably if you're going to a posterior, let's say I'm placing an implant in 1/7 and I'm unable to take the wrench in that area which is not accessible, then definitely yes. I mean, you can go with a cement retained restoration, but to make sure that it is retrievable, you can make sure that you have an access hole on the central fossa or at the prosthetic position. Limited mouth opening, restricted mouth opening, still yes, we can go ahead with SCRP. That's the main advantage of SCRP. But when it comes to anteriors, yes, I mean, you can directly go ahead with SRP rather than SCRP.
Okay. Another question: difference between cement retained and polymalo crown.
See, polymolocron is basically a double construction. The first framework will be screwed into the implant, and the second one, on the framework you will have projections again, just like your natural tooth preparations. On over the preparations, you will have a screw which is luted on. The main advantage of polymolo again is when the access holes are probably opening randomly, facially or buccally, where you don't want those access holes to be visible outside. You screw in the first framework inside the implants, make sure that it is passive, and then over the projections, you lute the cemented crowns, which make them more aesthetic, more pleasing to look at.
Great. Next question is: any guidelines for fracture screw removal? What can I, which I know you have answered very well. What can we do if threads in implant don't hold the abutment screw because of wear from repeated tightening?
See, if the implant threads have worn away, then see, one case I've tried by customizing the screw. I have made an impression inside the hex, the anatomy, and then I've customized the screw itself because we will not get the same screw again if we get from the company. So that's the only thing I have tried by looking into few literatures and articles. Otherwise, we can't do anything else if the implant threads are worn away. But if the screw threads are worn away, you can always change the screw.
Okay. Is cement retained processes with access hole in crowns a better option than screw retained processes?
Yes, again, it's the same answer. I mean, if you are going with probably an inaccessible area or limited mouth opening, yes. Otherwise, definitely a screw retained crown would be a better option if you have less prosthetic space again.
Okay. What precautions should be taken while giving screw retained processes when the implant is deeply placed and we have used 7 millimeter healing abutment?
Uh, to be very frank, see, there is a rule which is known as 2B 3D rule. 2B is 2 millimeters buccal bone surgically, and 3D is 3 millimeters, depth of an implant placement when it comes to the emergence profile, when it comes to the next tooth. So, if you are placing probably 7 down, then it is a prosthetic failure because you are giving a long vertical cantilever there. So you need not do anything else there. You just have to customize everything and place an implant, or do some augmentation initially, get the depth corrected, and place an implant at the right position.
Okay, so basically we are doing subcrestal placement to minimize micro movements as well as to prevent the tissue loss. But again, there is a limit how deep you can go. You cannot go beyond a certain limit. And you
Yes, sir.
said 3 millimeter is a good limit, and you better not cross that limit.
Cross that limit. Yes, sir.
Yes. Uh, how to reduce the steps of prosthetic parts? I mean, single step for jig trial, bite registration with perfection. Is it possible? And
No,
second
I
is the
don't.
direct fitting.
I don't think it's possible. They are coming up with some concept which is known as fire and forget concept, which is probably recently launched. I saw it in on Facebook also, where they're minimizing the steps by scanning. I have not still gone into that concept. So according to me, we probably have to follow those steps meticulously.
Next question, I think it's a very basic question. Is OPG enough for single implant cases in young healthy patients?
See, if you are asking me if the OPG is enough for placement and if the CBCT is not accessible for you, if you are probably working in a remote place, a village or probably a town where you don't have CBCT around, then there is a simple procedure which is known as bone mapping and a ball bearing method. You can use the combination of bone mapping as well as ball bearing method, get the width as well as height of the bone that is present arbitrarily. It will be nearer to the CBCT measurements. You can place an implant, but that's an alternative. I mean, if you definitely have a CBCT guided placement in the form of measurements, it's always better because you'll be getting the proximity to the anatomic landmarks as well.
Yes. Okay. Next question. Uh, kindly explain about difficulties during impression taking, especially during inserting impression posts in deeper placed implants and during delivery.
Yeah, I mean, see, if you asking me about the subcrestal placements, usually
I
the
think
problem
I think
with,
that
yeah, subcrestal, usually the problem is with the post. When you place a post, as I said, as I showed you in the X-ray, you just have to confirm with the X-ray that the post is correctly seated inside the implant. It is not, in way between somewhere. Make sure that it is correctly placed, and then you make an impression. That's the only thing. If the impression post is not going in inside the implant, you might have to look around for the bone which is actually acting as a restriction or some soft tissue, and then correct it and place an post inside the implant.
okay. I think this next question is about removal of the implant only, not the screw or the processes. A patient came complaining with headache after restore screw implant in 2/7. Now he wants to remove it. The reason he gives is headache. How to remove such implants? I think it is not.
uh, Please check if the headache is because of interference on the crown. I mean, if you have placed already an interference, because that's the most common interference that we see, the second molar area. I don't think that is related to the implant placement as such. I mean, if you have prosthetically placed, if you have respected the anatomic landmarks, if you have taken care of the placement of an implant, I don't think it should be the reason. So probably you just have to convince the patient that it is not the reason. Get him checked thoroughly for all the factors that are responsible for headache in multiple fields, and then rule it out. If you have given a crown, I ask you to probably remove the crown, place a temporary again, check for the occlusion well, see if the headache is coming down, and then go for a permanent restoration later on.
Looks more like an occlusal problem other than rather
Occlusion,
than
yes,
something
yes,
that requires implant removal.
implant removal, yes.
Yeah. Uh, clinical limitations with respect to available intraocclusal space for screw retained implant processes. Any correlation to available alveolar bone? I don't know. There are so many spellings missing here, and I tried my best to make sense out of it.
See, when it comes to the screw retain restoration, definitely yes. If you have less prosthetic space, then it's better you give a screw retain than a cement retain, because you'll always have this problem of getting the crown dislodged repeatedly. So go with screw retain restoration, enhance the retention of the crown. Number one. Number two, if you're asking about the bone space which is available, that is not related to either cement retain or screw retain. It is always related to the bone implant contact. I mean, if you have good amount of bone, good amount of implant contact with the bone. That's it.
Okay. And now comes the last question. Why not tooth supported implant? I think he's talking about tooth implant connection.
Okay, TISP. See, there are many things. I mean, the tooth is getting infraoccluded in the socket. Number one, if you're actually connecting that tooth with an implant, then definitely there is a possibility of osseointegration versus tooth movement inside the socket. So one of the things might fail. There are concepts where they're giving non-rigid connectors also, but you have to be very very careful with the occlusion when you go with TISP. I usually don't prefer tooth implant supported prosthesis until and unless it cannot be avoided. Then I check with the occlusion, make sure that there is no discrepancy between the tooth movement as well as the implant movement, and give a tooth implant supported prosthesis. Otherwise, better you avoid it.
Great. So that completes all our questions as well. So it was a wonderful session. You made
Thank you,
it
sir.
very, very simple for, I think, people who missed it will be able to watch the recorded sessions again. And these are available on 7 to 8 locations on Facebook as well as on YouTube. On Dr. Surabhi Mahidhar's page also, this was broadcast. So you can always go back and watch the recorded sessions. And what we are going to do for the people who have missed the live session is in 2 3 days, we'll be sending you the summary of today's session along with the links to the recorded sessions. And I thank Dr. Surabhi Mahidhar for accepting our invitation and doing full justice to this topic of implant prosthetics. And I wish him all the best in his implant education, student groups, and all the guidance and coaching he's doing through many of the projects that he has founded. And hope to see him again in one of our future events. And thank you for joining for today's event. And ICPA Clinical Series will be back after a few weeks with its fifth episode with a new topic and a new speaker. Hope you all had a great time today and let us meet you all soon. Thank you
Thank you,
so
sir.
much. Good night. Bye,
Thank
Dr.
you.
Surabhi
Thank you, sir.
Mehta. It was
Bye,
very
sir.
nice
Thank you.
having you here.
Thank you, sir. Thank you so much. Bye, sir. Good night. Good night.
Bye. Good night.